We will see the other class of drugs called as anticoagulants. So the name itself indicates they are acting against the coagulation. So anticoagulants are the drugs which are reducing the coagulation capacity of the blood. So the blood have, because of the platelets or thrombocytes which are present in the blood, that are causing clot formation. So it is reducing the platelets to clot. So it is reducing clotting capacity of the blood. So these drugs are tend to prevent the new clots which are tend to prevent the new clots. So these drugs, they won't allow any new clot formation. So there will be existing clots. These drugs, they never clot, they never dissolve the existing clots, but they prevent the new clot formation, and even they prevent the expansion or extension of the existing clot. And these are also given to certain people who are risk with forming of blood clots. So in the sense, we can predict that by the biological functions of their body, we can say that this person is more prone to clot. If there is any high thrombocyte count, then we can say that this person is having more blood clot formation, chances of more blood clot formation. So in such people, we can give these drugs prior in order to prevent the blood clot formation. Let us see the classification of anticoagulants. These anticoagulants are divided into two types, in vitro as well as in vivo. So in vivo are the drugs we are giving into the body from external source, and in vitro drugs are the drugs which are naturally synthesized in the body. So here in vivo drugs are further classified into parenteral anticoagulants and oral anticoagulants. So this parenteral anticoagulants are further classified as heparin and its derivatives. So in this heparin also, there are low molecular weight heparins and high molecular weight heparins. So high molecular weight heparins include unfractionated heparin, and low molecular weight heparins include enoxaparin, dalteparin, tinazepam, and reviprin, and danaperoid. So these are the low molecular weight heparinoid analogues. Now let us see heparinoids. So heparinoids, they are similar in structure with the heparin, and they include heparin sulfate, hirudin, lepirudin, bivalirudin, and argatroban. Let us see the classification of oral anticoagulants. So these oral anticoagulants are further classified into coumarin derivatives and indeldione derivatives. So coumarin derivatives include bis-hydroxycoumarin, which is also called as dicumarol, and warfarin sodium, acenocumarol, which is also called as nicomalone, and ethynyl biscoumacetate. And the indendione derivatives include phenandione. Now let us see the in vitro drugs. So what are the in vitro drugs? The drugs like heparin, sodium citrate, sodium oxalate, and sodium editate. So these are the compounds which are synthesized in the body because of the various chemical reactions. For a blood to clot, in order for the clot formation, there are various factors. There are 13 number of factors which are aiding in the formation of clot. So if we see the clot mechanism, or if we see the clot cascade pathway, in that all these 13 factors, they are aiding in the clot formation. So here the factors which are involved in the clot formation are factor 1, which is also called as fibrinogen, factor 2, prothrombin, factor 3, which is called as tissue factor or thromboplastin, factor 4 is calcium, factor 5 is proaxillerin or labile factor, and factor 6, which is not an independent factor, in the sense this factor is not given any name, but recent research has said that this factor 6 is called as axillerin. So because it promotes the formation, or it aid in the acceleration, or it aid in the fast clot formation. So that is the reason this name is given to this factor. The other factor, 7th factor, is proconvertant, which is also called as stable factor. Factor 8 is antihemophilic factor or globulin factor. 9th factor is antihemophilic factor B, which is also called as Christmas factor. Factor 10 is Stewart-Prober factor. Factor 11 is plasma prothrombin antecedent factor. Factor 12 is Hageman factor, and factor 13 is fibrin stabilizing factor. So all these factors, they aid in the clot formation. Now let us see the pharmacology of individual drugs. So this heparin, in order to show its pharmacological property or in order to show its anticoagulant property, it should have few characteristic features. So this heparin, it is first discovered by a person called as MacLean, and the word heparin is given by the persons called as Howell and Holt. So these are the persons who gave this compound a name called heparin in 1918. And this heparin is mainly occurring in the mast cells. So from the mast cells, histamine is released, along with that heparin is also released. So these mast cells are richly present in liver, lungs and intestinal mucosa. This heparin can be synthesized artificially or commercially. So the commercially synthesized heparin, it is synthesized from the porcine intestinal mucosa. From the porcine, the intestine of the porcine, this heparin is prepared, and from bovine lungs. So from the lungs of the bovine, this heparin is prepared. And this heparin, it is a mixture of straight chain glycosaminoglycans. So here glycosaminoglycans, glycose in the sense they contain the carbohydrate or sugar moiety along with the amino acid moiety. So it is a straight chain linkage of this glucose and amino acids, and this heparin is, there are various categories of heparin based on the molecular weight. For example, low molecular weight heparin and high molecular weight heparin. And these heparins are strongly acidic in nature because of the presence of the carboxylic acid group. So they contain COOH group in the structure, and because of that they are acidic in nature. Let us see the mechanism of action of heparin. So this mechanism of action of heparin exhibits in two ways. So one thing, if the heparin is given in low doses, it prevents the conversion of factor 10A, or it inhibits the factor 10A. So 10A is one of the factor which is aiding in the clot formation. So this factor is inhibited and thereby preventing the clot formation, and it also inhibits the conversion of prothrombin to thrombin. So prothrombin is an inactive form, so this inactive form has to be converted into active form in order to produce clot. So this formation is inhibited by the heparin when it is given in low doses, and if the heparin is given in high doses, it inhibits the factors like 9, 10, 11, 12 and thrombin. And it also inhibits the conversion of fibrinogen to fibrin. So if the fibrinogen is not converted to fibrin, then there occurs no clot formation. So here we can see the mechanical cascade pathway. Here the factor 13 is converted to 13A, and then 11 is converted to 11A, and 9 is converted to 9A. So here the clot formation occurs in two pathways, extrinsic pathway and intrinsic pathway. So the extrinsic pathway occurs because of the tissue factor. So because of the tissue factor present, then this pathway occurs, and because the contact activation, or else we can say that because of the activation of few because of the activation of few chemical mediators, then this type of intrinsic pathway can occur. So because from the damaged surface, so if there is any damage, from this the process occurs, and thereby finally the clot is formed. So this drug called heparin, it binds to a compound called as antithrombin 3. So this heparin, so it binds to this drug, and thereby it forms an heparin antithrombin 3 complex. So this complex, it prevents the formation of clot. Let us see the comparison between low molecular weight heparin and high molecular weight heparin. So if we see, the molecular weight of high molecular weight heparin is more, that is about 30,000 daltons, and low molecular weight is about 5,000 daltons. And when compared to the low molecular weight heparins, high molecular weight heparins are having low biotransformation reaction, in the sense they undergo low metabolic reactions, whereas because of the straight chain, because of the long chain in the structure, so they are undergoing metabolism very low when compared to low molecular weight heparin. And the half-life of high molecular weight is short when compared to low molecular weight. And the mechanism of action, so this high molecular weight heparins act by inhibiting the factors like 2A and 10A, whereas the low molecular weight heparin inhibits only 10A factor. And the when compared to low molecular weight heparin, high molecular weight heparins are more potent to prevent the coagulation. In the sense, they are having more they are having more capacity to prevent the coagulation. And here the prothrombin time, so the activated prothrombin time has to be monitored. So because see the prothrombin time, in the sense the formation of or the conversion of prothrombin to thrombin, so this time has to be monitored, or else this prevention of this conversion time should be monitored while giving this low molecular weight and high molecular weight drugs. And the adverse drug reactions with high molecular weight include, it may cause thrombocytopenia. So as these reduce the clot formation, thereby the thrombocytes count is reduced. On higher doses it may lead to thrombocytopenia, and on long term usage it may lead to osteoporosis. And when compared, if we see the adverse effects of low molecular weight heparin, they are having less adverse effects when compared to high molecular weight heparin. And those high molecular weight heparins are cleared or they are eliminated out through reticuloendothelial system, whereas low molecular weight heparins, they are eliminated out of the body through kidneys and they are eliminated in unchanged form. And here the reversal, or is the reversal capacity of this high molecular weight is done by protamine as well as this low molecular weight reversal, or else the activity of this low molecular weight reversal cannot be the activity of this low molecular weight compounds cannot be reversed. And if we see, the high molecular weight heparins are less expensive when compared to low molecular weight heparins. Let us see the advantages of the low molecular weight heparins over high molecular weight heparins. How far these low molecular weight heparins are useful. So here they have better subcutaneous availability. So these low molecular weight heparins, if we are giving through subcutaneous route, they are available in the systemic circulation. Like low molecular weight heparin bioavailability is 70 to 90%, whereas high molecular weight heparin bioavailability is 20 to 30% through subcutaneous route. And they are having better half-life when compared to high molecular weight heparin. And even the prothrombin time has to be the prothrombin time cannot be there need not be monitored for this low molecular weight, so which is a task factor for the person or the clinical practitioner who is monitoring this prothrombin time. And even it lowers the incidence of hemorrhagic complications. So if we use these heparins for longer period of time, that may lead to excessive loss of blood leading to hemorrhage. So this consequence or the chances of hemorrhage with this low molecular weight heparin is very low when compared to high molecular weight heparin. And this low molecular weight heparin, they causes or they decrease the antiplatelet action. So they decrease this low molecular weight, they won't allow the platelets to form the clot, and thereby they are decreasing the interference with the thrombosis. In the sense, they are not aiding in the clot formation in the blood vessel. Thrombosis is nothing but the formation of clot in the blood vessel. So this event is blocked by this low molecular weight heparins. Let us see the pharmacokinetics of these drugs. So because of the high chains or else because of the highly charged groups, so these heparins are containing acids as well as bases in their structure. So here they form charged ions, either COO minus or NH3 plus. So because of the charged ions, if the ions are charged, then they are not easily crossing through the plasma membrane. So ions are never crossed through the plasma membrane. So that is the reason they are not entering into the cell properly, and that is the reason they are giving through parenteral route. So parenteral route are more effective when compared to oral route. And here low dose is required. So low dose is given through subcutaneous route, whereas high dose is given through subcutaneous as well as IV route. And the metabolism is done by the liver. The metabolism occurs in the liver, and the half-life of these drugs depend on the dose. So if the dose is given low, then the half-life is short, and if the dose is given high, then the half-life is long. So half-life depends on the dose of the drug given. If we see the pharmacological actions of this drug, they are having anticoagulant activity. So they prevent the formation of clot, thereby exhibiting the anticoagulant activity. And they are powerful and instantaneously acting. So they are more potent and they are effective both in vivo as well as in vitro also. So this heparin is given through in vitro route as well as in vivo route. So in both the routes this heparin is very effective, and certain stoppage of the dose. So here we should not stop heparin all of a sudden. So if we stop heparin all of a sudden, then it may lead to the withdrawal syndrome, and thereby there occurs rapid coagulation in the body. And antiplatelet effect. So antiplatelet effect in the sense, in higher doses, the heparin, if we give the heparin in higher doses, it inhibits the platelet aggregation. So the platelets have to aggregate, or the platelets have to mass, or they have to form a clump in order to form a coagulation. So here the platelet aggregation is inhibited if heparin is given in higher doses, and it even prolongs the bleeding time. So here the time taken for the blood to ooze out of the body is prolonged, or it is extended by this heparin. And how it is helping, or what are the actions in lipid clearing, how these are clearing the lipids. So this heparin, when it is injected, when low dose of heparin is injected, it releases an enzyme called as lipoprotein lipase. So this lipoprotein lipase is an enzyme which is aiding, or which is breaking down or degrading the fatty acids. So if the hydrolysis of the fatty acids are taking place, then the deposition of these fatty acids at the blood vessel will be reduced, and thereby there will be free flow of the blood. So let us see the adverse drug reactions, or what are the adverse effects of these heparins. So bleeding, if they are used for chronic period of time, they will prolong the bleeding time, and thereby it leads to hemorrhage. They causes allergic reactions. They causes severe anaphylactic reactions. These are the type of hypersensitivity reactions, and they causes alopecia. That is the ability of the, or as we can say, the ability of the body to form the cells, the ability of the body to produce the antibody against the infections. And long-term they may cause osteoporosis when they are used on long-term basis, and they cause thrombocytopenia, that is decrease of platelets in the body. So what are the drug interactions with this heparin? So heparin, if it is given in corticotropin, so if the heparin is given with corticotropin, then it increases the toxicity of this drug. So if the drug toxicity is increased, then it leads to severe hypotension. There will be severe fall of blood pressure. And this heparin should not be given with mifepristone, because this mifepristone, if it is given with mifepristone, it will cause excessive post-abortion bleeding. So after abortion, the bleeding will be more if this drug is given with this mifepristone. And this heparin should not be given with aspirin, because it increases the anticoagulation. So it will not allow the blood to coagulate. If the blood is not coagulating, it will lead to severe hemorrhagic conditions. And this heparin should not be given with fluorouracil, because it will cause, excessive bleeding will be there. And this heparin should not be given with mipomersen, because it will increase the hepatic enzyme levels. So if the hepatic enzyme levels are increased, there will be severe metabolic reactions. Heparin, how the heparin is used in pregnancy. So if the heparin is given in pregnant women, it does not cross the placenta. As this heparin is having the high molecular weight, and these are charged ions. I told you these are charged ions. So these charged ions never cross the plasma membrane. So if they are not crossing the placental barrier, and thereby this should be, because they cannot cross the placental barrier, then warfarin is replaced with heparin during pregnancy. And warfarin, it crosses the placental barrier easily, and thereby it causes changes in the fetus. So there occurs changes in the fetus, and which is not, changes in the fetus occur to cause fetal warfarin syndrome, and thereby that is not that good for the baby. Now let us see the contraindications. So when should this heparin be contraindicated? This should be contraindicated in hypersensitivity reactions, because heparin can potentiate the anaphylaxis, and we should not give this in hemophilia conditions. Hemophilia is nothing but where there is the decreased, where there is the increased blood clot, where there is the decreased platelet count leading to the excessive bleeding, and thrombocytopenia condition, intracranial hemorrhage if there is any hemorrhage in the cranial region, and gastric intestinal ulcers, and threatened abortion if there is any abortion, and even in advanced renal or hepatic disease. So in all these conditions, this heparin should be contraindicated. Let us see the uses of heparin, in where this heparin is used. So heparin is used in the treatment of deep vein thrombosis. So if there is any clot formations in the veins, then in order to prevent these clots, this heparin is given in immobilized patients, in elderly people, and in post-operative. So after the operation, if there is any clot formation, and post-stroke patients who had stroke before, and leg fractures if there are any leg fractures or electric surgery. So in all these people, the thrombus which is formed in the veins, that can be the thrombus prevention can be done by this heparin. And it is used in heart diseases for unstable angina. So for unstable angina and myocardial infarction, it is used, and it is also used after angioplasty and coronary artery bypass graft and instant replacement. So in all this, it is used as a prophylactic agent, and it is used in rheumatoid arthritis in order to reduce the stroke because of the embolus formed. So embolus is again a clot formation, whereby this in order to decrease this or else because of the clot formation, because of the embolus formation, there occurs stroke. So the stroke prevention, the events of the stroke can be reduced in rheumatoid arthritis by this heparin. And in cerebrovascular diseases, so if there is any clot formation in the cerebral tissue, or if there is any clot formation in the cerebral vascular tissue, then this can be prevented by this heparin. In vascular surgeries or in heart surgery, so if there is any surgery for heart valve replacement or any cardiac related surgery, this heparin is used. And in defibrillation syndrome, so prevention of fibrins, so in defibrillation syndrome, or if the fibrins clot is forming more, if the fibrins are converted more, in that condition, it is used in order to prevent infections, and it is used in thrombosis condition, and it is used in thrombosis in order to induce thrombocytopenia. So if in thrombosis condition, if this heparin is used for longer period of time, then it leads to thrombocytopenia, and if the thrombocytopenia occurs, then that cannot be treated because there is no antidote available for this heparin caused thrombocytopenia. And the adverse drug reaction in this condition is that the antibody formation against thrombin-lupyridine complex. So here, because of this thrombocytopenia condition, then it leads to the formation of thrombin-lupyridine complex, which is the adverse drug reaction of this heparin. Now let us see the heparin antagonist. So how we have to antagonize the severe actions of heparin. So the drugs like protamide sulfate are given. So protamide sulfate is one of the antagonists of heparin, and it is strongly basic in nature. So as the heparin is strongly acidic, in order to antagonize it, so strongly basic compound is given, and it is low molecular weight, and this is obtained from the sperms of fish. So this is extracted from the sperms of fish, and this is given mostly through IV route. So if we give through IV route, then it is available in the systemic circulation, because this heparin is given through IV or subcutaneous route. So if we prefer to give it through IV route, then it can antagonize the adverse effects of heparin. And in the absence of heparin, protamine itself acts as a weak anticoagulant. So if heparin is not there in the blood and we are giving protamine sulfate, then it shows the anticoagulant activity instead of antagonizing the heparin effect. The other drugs are heparinoids. So heparinoids are the drugs which bind to thrombin without additionally binding to proteins such as antithrombin. So if we see heparin is binding to a protein called as antithrombin 3, and it is forming antithrombin 3 complex. But these heparinoids are the drugs which never bind to the antithrombin proteins. So they directly exert the anticoagulant action by inhibiting the factors. So the drugs which come under this category are hirudin and bivalirudin, which bind both at the site of thrombin. So they prevent the formation of prothrombin to thrombin, and even they also bind at the substrate recognition site. So here the prothrombin is converted to thrombin, and this thrombin has to bind to the receptor site or substrate site and thereby to show clot formation. So this clot formation or the site of binding of thrombin is inhibited by these drugs. And ergotrabein is a drug which binds to the thrombin instead of which binds to the thrombin site instead of thrombin. So it won't allow the thrombin to bind it at its receptor site. So this drug replaces the thrombin and thereby preventing the action of thrombin. The other drug is leperidine, and leperidine is a drug which has to be monitored because on on long-term usage it may cause hemorrhages. So the bleeding time should be monitored for this drug, and this action is independent of antithrombin in the sense it is directly preventing the it is directly inhibiting the factors. The other drug is bivaluridine. It inhibits the platelet activation or the platelet aggregation is inhibited by this drug. It is used in percutaneous coronary angiography. The other drug is ergotabaterin. Ergotabaterin is used, it is used in heparin-induced thrombocytopenia. So here, because of the long-term usage of heparin, thrombocytopenia occurs. So it is used to treat this type of syndrome, and this also has to be monitored. So the bleeding time of this drug has to be monitored, and the dose should be reduced if a person is having liver disease. Now let us see the other category of drugs, oral anticoagulants. So here the oral anticoagulants, the drug which come under this category is warfarin. So warfarin is a synthetically derived coumarin. So it is a derivative of coumarin. So from the structural changes of coumarin, this warfarin is obtained, and it is prescribed to the people with increased tendency for thrombosis. So here who are having, in the sense these oral anticoagulants are given who are, if we predict that they are having the more chances of coagulation, in such conditions this warfarin is given, and this is contraindicated in pregnancy. If we see the mechanism of action of warfarin, so this warfarin, it inhibits the calcium dependent clotting formation. So here the factors, in order for the factors to get converted, calcium is also one of the important factors which is aiding in the clot formation. So these oral anticoagulants, they prevent the conversion of vitamin K epoxide to vitamin K hydroquinone. So this is one of the major conversion in the clot formation. So thereby it is preventing the conversion of prothrombin to thrombin, and various clotting factors are inhibited. So if prothrombin is not converted to thrombin, then the clot formation won't occur. If we see the pharmacokinetics of this warfarin, if we give through oral route, it is 100% bioavailable. 100% of the drug reaches the blood, and thereby it is distributed all over the body, and it is having high plasma binding capacity. So it is more bound to the plasma proteins, that is up to 99%. And it even crosses the placental barrier, which is teratogenic. It is not that good for the baby. And the drug, if we give the drug, it appears in the milk, and thus infants are given vitamin K. So here, as warfarin, it prevents the vitamin K conversion. So if we are giving this in children, then the vitamin K supplements are also have to be given, and this shows hepatic clearance. So this drug is cleared through liver, and the metabolism occurs in the liver by the process called as oxidation and glucuronidation. So these two are the biotransformation reactions occurring in the liver. So this warfarin is metabolized by this process of oxidation and glucuronidation in the liver, and it takes almost 12 to 16 hours for the warfarin to show its effect. So if we see the adverse drug reactions of warfarin, the common adverse drug reaction is that bleeding. So on long term usage it causes hemorrhage, and it even causes bleeding in gastrointestinal region, and it causes internal hemorrhages, internal bleeding of the organs, hematuria. These are all the common side effects. If we see, it causes cutaneous necrosis. So it causes damage to the tissue, or else it causes the damage to the, if we give through subcutaneous route, it causes necrosis or damage at the particular site due to the decreased activity of protein C. So protein C is one of the main protein which is aiding in the development of the tissue. So this is inhibited, or this is the activity of this protein C is decreased, and thereby there occurs necrosis or damage to the tissue. And it causes infarction of the breast, fatty tissues, intestine as well as extremities. Here these tissues are replaced by the fibrous tissue or other adipose tissues, and thereby it causes the, it leads to the various adverse drug reactions. Hypoactivity of warfarin causes. If this warfarin, if this warfarin is not showing the therapeutic effect, or if we are giving this warfarin in low doses, or it is not showing any effect, what happens? So it is affected in pregnancy, because during pregnancy, if there is any blood clot, then there occurs severe problems. So if the warfarin is not showing its effect, there causes blood clot, and it causes the nephrotic syndrome. So there occurs the clot in the nephrons or kidneys, and warfarin resistance. So the person will resist the person will become resistant to warfarin. If we give warfarin also, this drug will not show any effect. What happens if warfarin is given in higher doses, or if the warfarin is showing its action in excessive? What happens? It causes malnutrition. So it will cause the deficiency of vitamin K. So as it is inhibiting the vitamin K conversion, it causes malnutrition. It affects the newborns. So it is affecting newborns because of the vitamin K deficiency. It causes liver diseases, and it causes chronic alcoholism. So the person will have, in the sense, the person will be more prone to take alcohol, and it causes hyperthyroidism. The person will have thyroid related disorders. So if warfarin toxicity occurs, then it leads to severe hemorrhage. Though, at this situation, what we have to do? So first thing is that we have to stop taking warfarin. So warfarin should not be given, and instead of that, we have to give vitamin K. So we have to administer vitamin K, because vitamin K is an antidote for warfarin poisoning. And the following has to be taken. We have to take care that fresh frozen plasma should be given. So we have to extract plasma, and we have to store it, and the fresh frozen plasma is to be administered in order to antagonize the toxicity of warfarin. Prothrombin complexes concentrates, the prothrombin supplements are given, and recombinant factor 7A. So this 7A, it is prepared through recombinant technology, and that has to be administered in warfarin toxicity. When should this warfarin should be contraindicated? So this warfarin should be contraindicated in pregnancy, because it leads to the fetal defects, and it causes abnormal bone formation in the fetus. It causes bone hyperplasia, CNS related disorders, and it sometimes causes fetal hemorrhage also, and thereby finally there occurs fetal death. So in these conditions, in pregnancy conditions, the warfarin should not be given. What are the drug interactions? So how the warfarin is interacted? So there are pharmacokinetic interactions and pharmacodynamic interactions. So pharmacokinetic interactions. So the drugs, if the warfarin is given with some drugs, they causes inhibition of warfarin metabolism. The drugs like cimetidine, imipramine, cotrimazole, chloramphenicol, ciprofloxacin, amiodarone, and metronidazole. So these are the drugs which should be contraindicated with warfarin, because this warfarin will interact with these drugs, and thereby the metabolism of warfarin is prevented. The drugs which increase the warfarin metabolism, so the drugs like barbiturates and rifampicin, so they excessively metabolize the warfarin, and thereby the warfarin is not showing any therapeutic effect. And the drugs like chloral hydrate and NSAIDs, they won't allow the warfarin to bind to its site. So if the warfarin is not binding to its sites, it does not show the anticoagulant property. So these drugs are displacing the warfarin to bind its site. So that is the reason these drugs are not, the warfarin should be contraindicated with these drugs. and it should not be given with cholestyramine drug because it decreases the GI absorption of warfarin. So cholestyramine is an anti-atherosclerotic drug. So this drug should not be given with warfarin because the warfarin absorption won't take place. So if we see the pharmacodynamic interactions of warfarin, it shows synergistic effect. So if the warfarin is given with heparin and aspirin, then it shows synergistic effect. It causes excessive bleeding. And this warfarin should not be given with antibiotics because this warfarin, it inhibits vitamin K. So vitamin K is essential, or else we can say this if this warfarin inhibits vitamin K, and if this is given with this antibiotics, there are bacterial flora. This is, there are the microorganisms or bacteria which are present in the intestine. So these are very essential bacteria which are needed for the body. So if we give antibiotics, the antibiotics kill the intestinal flora and thereby they inhibits the vitamin K synthesis, because these bacteria, they aid in the synthesis of vitamin K. That leads to the vitamin K deficiency. So that is the reason warfarin should not be given with antibiotics. What are the uses of the warfarin? So warfarin is used same as that of heparin. It is used in heart-related disorders, in rheumatoid arthritis, and even it is used as an anticoagulant, antiplatelet. So the uses are same as that of heparin, but here the warfarin dose should be monitored because warfarin belongs to low therapeutic index drug. So if the dose exceeds, then it shows toxic effect, and if the dose decreases, then it shows no effect. So the dose of the warfarin has to be monitored, and even the prothrombin time should be monitored. So the time for the conversion of prothrombin to thrombin should be monitored, and it is given through, the patients who are not prone, or else who are having the problem with heparin. So in few patients, the heparin shows side effects. So in these conditions, so we are giving heparin through IV route. They may cause some rashes at the site of injection. So the discomforts which are caused because of the heparin, then in that cases, the warfarin is given through oral route instead of heparin. If we compare the warfarin and heparin, so what are the comparisons between warfarin and heparin? So here the heparin is given through oral route, the heparin is given through parenteral route, whereas warfarin is given through oral route. And the heparin is in charged molecules, in the sense the heparin contains anions or charged structures, whereas warfarin is in uncharged. It is not a charged molecule, and the onset of action of heparin is very fast. But here the warfarin is having the onset of action, in the sense the after administration of 12 to 16 hours, then the warfarin shows its effect. The mechanism of action is that heparin, it binds to the antithrombin 3 factor, and then it shows its anticoagulant action. But this warfarin, it inhibits the gamma carboxylation of the glutamic acid, and thereby it is decreasing the clotting factor. So here the gamma carboxylation occurs. The glutamine is an amino acid through which the carboxylation occurs. So to the glutamic acid, the carboxylic group is added. So this action is prevented. And the therapeutic index of this drug is the therapeutic index of heparin is not low. The therapeutic index of the heparin is not low, and thereby it is safe to use, whereas the warfarin is having higher therapeutic index, and thereby the dose has to be monitored. And the adverse drug reactions of heparin include like alopecia, osteoporosis, thrombocytopenia, and that of warfarin it causes cutaneous necrosis, breast and other fatty acid infarction takes place. And here the heparin has to be, the medication or the management has to be given. First heparin has to be given to the patient, and then only after 3 to 5 days of heparin treatment, this warfarin is recommended. So the warfarin is not given initially. And the antidote for heparin is protamine sulfate, and that of warfarin is vitamin K. And this heparin should be contraindicated in pregnancy, whereas the heparin is not contraindicated in pregnancy, whereas the warfarin is strictly contraindicated in pregnancy. And the heparin is not having much significant drug interactions, whereas warfarin is having various drug interactions.